Every day you choose to move, your body responds with strength, balance, and renewed life. Each gentle motion is a gift to yourself, calm, mindful, and full of vitality. Together we move, we heal, and we thrive. Keep the rhythm of your golden years. Nurture health, cherish every movement. Recent research has revealed 5 particular workouts that consistently enhance older persons' capacity to ascend and descend stairs, contesting the prevalent belief that stair difficulty is an inevitable result of aging. Until recently, several exercise regimens for older persons prioritized overall strength as the principal solution for mobility deterioration. Converging evidence from clinical programs, laboratory studies, and observational cohorts suggests that a significant portion of the functional impairment experienced during stair negotiation results from declining neuromuscular patterns and deficits in fine motor control rather than merely a deficiency in maximal muscle strength. Surveys and observational studies have revealed that a significant number of individuals over 60 have challenges or worry concerning stairs. In one representative poll, approximately 3/4 of respondents in this demographic reported experiencing stair-related difficulties. In that same body of research, investigators made a notable observation. Individuals who maintained effortless stair mobility into advanced age, some remaining adept on stairs well into their 70s, consistently exhibited 5 specific movement patterns, often excluded from conventional fitness regimens. The developing evidence base has transformed clinical practice and exercise prescription towards interventions that specifically retrain movement patterns, restoring static holding capacity, isometric endurance, eccentric control during descent, lateral pelvic stability for single-leg support functional power through the hips and knees, and ankle propulsive power along with endurance. When implemented in practical environments, these tailored therapies have yielded encouraging clinical outcomes. A substantial clinic-based program implementing these ideas for elderly individuals demonstrated significant enhancements in stair confidence and functionality within 2 months without the need for specific equipment. Laboratory observations indicating that concise, targeted daily practice could result in significant improvements prompted replication initiatives in academic institutions and clinics, reinforcing the notion that retraining neuromuscular patterns rather than exclusively emphasizing maximal strength, offers an effective and pragmatic approach to restoring stair functionality. This new paper aims to furnish doctors, therapists, and older persons with explicit, actionable information for reconstructing the neuromuscular patterns essential for stair climb and descent. The 5 exercises outlined below wall sit step-downs, standing hip abductions, sit-to-stands, and heel lifts with isometric holds were chosen for their direct biomechanical applicability to stair duties, their practicality in various environments, and their potential for safe progression. This guide offers reasoning physiological background, precise execution cues, progression tactics, typical errors and corrections, and clinically pertinent adaptations for each exercise. The objective is not merely to dictate movements, but to re-establish coordinated control, timing sequencing, and endurance during successive changes. These abilities are crucial not only for navigating stairs, but also for a wide array of daily activities that facilitate independent living. Clinical evaluation and safety assessments prior to initiation. Prior to initiating any new fitness regimen, especially in older adults, assessing cardiovascular, musculoskeletal, and neurological risk factors is advisable. A preliminary safety assessment ensures participant safety and informs adjustments for comorbidities, recent surgeries, or sensory deficits. Fundamental safety guidelines encompass medical clearance individuals with unstable cardiovascular conditions, uncontrolled hypertension, recent myocardial infarction, symptomatic arrhythmias, or acute orthopedic injuries must secure approval prior to advancing beyond gentle mobility exercises. In cases of uncertainty, consulting a primary care physician or obtaining cardiology clearance is advisable before advancing to higher intensity or unilateral loading progressions. Balance and fall risk. Individuals with severely compromised balance, recent falls, or progressing neurological disorders should commence training under supervision. Physical therapist exercise, physiologist, or qualified clinician, and may necessitate assistive equipment during first training. Supervised sessions alleviate anxiety, guarantee proper technique, and facilitate incremental exposure to demanding single-leg tasks. Joint disease individuals with symptomatic osteoarthritis in the knees or hips should implement adaptations, limited range, gradual progressions, and regularly monitor pain. Transitory delayed discomfort is anticipated, but severe or escalating pain necessitates reevaluation. Prioritize pain-free ranges and contemplate analgesic or activity timing methods. Engage in exercise during periods of minimal pain. Medication evaluation. Beta blockers or other agents that attenuate heart rate response may influence perceived exertion. Advise participants to utilize perceived effort scales, e.g. Borg scale, and observe symptoms instead of depending exclusively on heart rate. Additionally, evaluate drugs that elevate the risk of falls, such as sedatives, and collaborate with prescribing clinicians as necessary. Footwear and environment. Utilize supportive non-slip footwear and engage in exercises within unobstructed regions featuring a stable surface or close handhold. When utilizing home stairs for testing or practice, ensure sufficient illumination, non-slip treads, and readily available handrails. Basic baseline evaluations facilitate the identification of intensity levels and monitor advancement. Valuable clinical assessments comprise 30-second sit-to-stand assessment, quantity of stands during 30 seconds. Normative ranges differ by age and sex. A valuable clinical benchmark is achieving 15 stands in 30 seconds, indicative of adequate lower limb functional power for numerous older persons. Timed ascent of stairs over a predetermined number of steps. For instance, the duration to ascend 8 to 12 steps, or assessed vertical distance. Document the height of the steps utilized and indicate whether the railing was employed. Timed up and go. Tug, standing from a chair traversing 3 meters, pivoting, returning, and resuming a seated position. Single leg balance duration, eyes open, assessed to a comfortable maximum, often up to 30 seconds. Patient-reported metrics: felt exertion during stair ascent, reliance on handrails, fear of falling, and stair confidence assessments. These assessments are economical, rapid, and adaptable to modifications through training. Document initial measurements and reevaluate every 2 to 4 weeks to track adaptation and inform progression. 1. The wall sit, developing isometric endurance. Objective and operational significance. The wall sit enhances isometric endurance, the ability to maintain a static muscle contraction for prolonged durations. In stair climbing, recurrent transitions frequently involve brief static or near-static phases, during which the quadriceps and gluteal muscles maintain the knee and hip at a fixed angle as the body readies for the subsequent push. Enhancing the capacity to maintain that position mitigates tiredness, sustains alignment, and averts hasty compensating methods that elevate fall risk, including swift foot placement, excessive dependence on handrails, or anterior trunk collapse. Biomechanics and physiological justification. The quadriceps group facilitates knee extension and serves as the principal anti-gravity support during weight-bearing phases of stair ascent. Isometric contractions entail force generation without altering muscle length. They yield adaptations in muscle endurance, local metabolic tolerance, enhanced capillary density, and oxidative enzyme activity, and motor unit recruitment strategies that are distinct from those resulting from concentric or eccentric dynamic training. The stair cycle necessitates maintaining mid-range joint angles, making training at that joint location particularly specific and transportable. Isometric training enhances neuronal regulation of posture and co-contraction patterns that stabilize the knee and hip during static phases, which is crucial for minimizing knee buckling during transitions and controlling step placement under fatigue. Comprehensive implementation. 1. Assume a position with your back flat against a robust vertical surface wall. The feet should be positioned at a width ranging from the hips to the shoulders and aligned forward. 2. Foot positioning. Advance both feet forward until your shins are almost vertical. The forward distance is contingent upon limb length and comfort. The standard spacing is around 2 feet from the wall for an ordinary adult. Taller individuals may extend their distance marginally. 3. Descent. Gradually lower your back against the wall until your thighs are nearly parallel to the floor, forming an approximate 90-degree angle at the knees. Individuals experiencing knee pain or restricted mobility may first adopt a shallower angle of 100-110 degrees. 4. Weight distribution. Allocate weight through the heels and midfoot instead of the toes. Gently press the lower back against the wall and activate the abdominal muscles to sustain a neutral lumbar alignment. 5. Maintain relaxed shoulders and ensure even breathing. If the hold length is restricted, permit rest as necessary, and resume the position for further sets instead of enforcing extended holds with improper alignment. Respiration and cognitive signals. Practice rhythmic, diaphragmatic breathing. Inhale for 2 seconds and expel for 2 seconds to regulate intra-abdominal pressure and prevent Valsalva-like breath holding. Instruct participants to breathe as if speaking, maintaining a steady and continuous rhythm, particularly during extended periods. Frequent mistakes and rectifying prompts, knees deviating anteriorly or adducting valgus. Adjust the feet slightly posteriorly or broaden the stance. Instruct to apply outward pressure on the knees or gently compress a small ball between the knees to activate lateral stabilizers. Excessive lumbar extension. Slightly reduce the depth and instruct to tuck the pelvis while drawing the navel into the spine, ensuring the back remains in contact with the wall. Weight on the toes. Redistribute weight to the heels. Breath retention. Employ audio signals to exhale in a rhythmic manner. Advancement and modifications. Novices commence with 20 to 30-second holds, performing 3 sets with 60 to 90 seconds of rest between sets. Prioritize technique over duration. Quality supersedes time. Intermediate, incrementally increase by 5 to 10 seconds weekly as tolerated until achieving continuous holds of 90 to 120 seconds. Once 90 seconds becomes manageable, strive for 3 sets at that duration. Advanced, implement unilateral tasks such as single heel lifts during a wall sit or alternating heel lifts to enhance unilateral control. An alternative advanced technique involves executing brief alternating marching motions while preserving thigh alignment to replicate stepping transitions. Inserting a tiny ball or light band between the knees to highlight adductor co-activation can enhance stability requirements. Instruction in programming. Execute wall sits on alternate days to facilitate the regeneration of localized muscular endurance. The frequency may be modified according to soreness and the overall program load. Brief daily touch-up, holds 1 or 2 sets of 20-30 seconds, might reinforce the motor pattern without inducing severe tiredness. Clinical recommendations and anticipated modifications. Participants generally report enhanced ability to pause on steps, diminished tremors, and a decreased necessity to promptly hold handrails over a period of 4 to 8 weeks. Objective enhancements encompass prolonged hold durations and enhanced perceived stability during step transitions. Improvements indicate both local muscular endurance enhancements and an increased impression of stability, which are crucial for functional independence. 2. The step-down mastering eccentric regulation. Objective and operational significance. The eccentric control of step-down trains the capacity of muscles to elongate under stress while decelerating the body. Controlled eccentric strength is crucial for safe stair descent and for minimizing sudden collapses that result in loss of balance and falls. Efficient eccentric control enhances energy absorption, diminishes dependence on compensatory trunk movements, and facilitates precise foot placement on lower steps. Biomechanical and physiological justification. During a downward stride, the quadriceps eccentrically elongate to absorb body weight and decelerate the center of mass upon foot contact with the ground. Eccentric contractions generate greater force with reduced metabolic expenditure, induce distinct neural patterns, and promote changes in tendons and muscle tendon units that enhance resilience to loading. Age-related deterioration in eccentric control sometimes presents as heavy or uncontrolled step-downs, excessive reliance on handrails, or quick trunk flexion to advance the center of mass strategies that undermine stability and elevate the risk of falls. Thorough implementation. 1. Equipment. Utilize a low stable platform such as the bottom stair, a 6 to 8-inch aerobic step, or a robust box. Verify that the riser is stable and possesses anti-slip properties. 2. Initial position. Stand with both feet on the edge of the step. If necessary for stability, gently grasp a chair wall or railing but refrain from applying weight to the support. 3. Weight transfer. Transfer the entirety or the majority of weight onto the supporting leg and slightly flex that knee in preparation for the fall. 4. Gradual descent. Deliberately drop the contralateral limb toward the ground over a measured 3-second interval while keeping the torso erect and gaze directed forward. Refrain from using the upper body to pull the descending leg. 5. Touch and return. Permit the toes of the descending foot to make light contact with the floor without shifting full weight, then exert pressure through the heel and center of the supporting leg to return to the step. Revert to the two-legged rise step if required. 6. Repetition and leg alternation. Execute the assigned repetitions, then switch legs. Essential execution strategies. Visual focus. Maintain gaze at eye level to support upright alignment. Tempo vocalize or utilize a metronome to maintain uniform 3-second descents. Safety. Commence with low boxes and refrain from utilizing high risers until eccentric control is attained. Frequent mistakes and their rectifications. Rapid descent. A slow cadence and guidance to descend as if you have ample time are essential. Decelerating eccentric movements enhances neuromuscular regulation. Knee valgus inward collapse. Utilize tactile input, a mirror or a resistance band positioned above the knees to facilitate alignment. Execute brief hip abductor activation exercises, e.g. clamshells or side-lying hip rises, prior to step-down practice. Excessive trunk flexion. Instruct to maintain an upright posture and to hinge gently at the hips while preserving a neutral spine. Premature weight transfer. Stress. The need of retaining weight on the support leg until the descending foot makes contact with the ground. Advancement and program variables. Beginners perform 2 sets of 6 to 8 controlled step-downs per leg 3 times a week, emphasizing a 3-second descent phase. Intermediate progress to 3 sets of 10-12 repetitions each leg after 2 to 3 weeks. Advanced. Incorporate a light external load such as dumbbells or a weighted vest, progressively elevate step height, or execute an eccentric-only emphasis by descending with both legs and ascending with one to enhance absorption capacity. Another sophisticated technique involves gradually descending to a lower riser and stepping forward or backward to replicate authentic stair negotiation. Considerations for recovery and adaptation. Eccentric exercise generates increased mechanical stress at the muscle fiber level and may lead to delayed onset muscle soreness, DOMS particularly in the initial stages of training. Implement extended recovery periods of 48 to 72 hours between severe eccentric training sessions and recommend a gradual increase in intensity to mitigate pain while maintaining adaptation. Incremental increases in volume and intensity facilitate tendon remodeling and mitigate injury risk. Medical documentation. Eccentric capacity is distinctly specialized. Executing controlled step-downs effectively translates to descent requirements. Enhancements typically emerge as diminished reliance on handrails and fewer rapid compensatory movements within 4 to 8 weeks. 3. The standing hip abduction. ensuring lateral stability. Objective and operational significance. The standing hip abduction exercise fortifies the hip abductors, chiefly the gluteus medius, which stabilizes the pelvis during unilateral stance. Single-leg support phases on stairs are common and demanding. Strong hip abductors avert contralateral pelvic descent and ineffective compensatory strategies that elevate energy expenditure and fall risk. Biomechanical and physiological justification. During unilateral support, the hip abductors provide a counter moment to avert contralateral pelvic descent. Muscle weakness induces a Trendelenburg-like process, resulting in pelvic tilt and compensatory movements of the trunk and lower limb, e.g. lateral trunk, lean heightened frontal plane knee stress. The focused enhancement of the abductors enhances frontal plane stability, diminishes compensatory trunk lean, and establishes a firm foundation for efficient concentric and eccentric movements at the knee and ankle when navigating stairs. Thorough implementation. 1. Assume a position adjacent to a wall or a robust chair for minimal support. Feet aligned either together or at hip-width distance. 2. Weight transfer. Displace weight to the inner leg. Sustain a small flexion about 15-20 degrees in the supporting knee to mitigate impact. 3. Movement. Maintain the moving leg in a straight and neutral position, toes directed forward, and elevate it laterally, commencing the motion from the hip rather than the torso. Refrain from rotating the pelvis. 4. Range and cadence. Elevate only to a height that elicits tension in the lateral hip, typically 12-18 inches, maintain the peak contraction for 2 seconds, then descend with control over 2 to 3 seconds. 5. Execute the allotted repetitions, emphasizing fluid and intentional movement devoid of velocity. Progressive indicators and modifications. Promote muscle awareness by positioning a hand on the lateral hip to perceive contraction. Utilize a mirror to observe trunk alignment and pelvic elevation. For individuals struggling to isolate the hip, initiate with side-lying hip abductions non-weight-bearing to offer tactile stability and proprioceptive feedback prior to advancing to standing exercises. Frequent mistakes and their rectifications. Torso alignment. Instruct to maintain an upright posture and activate the core. Visualize balancing a book atop your head. Minimal fingertip support on a chair is permissible during initial practice. Commencing from the lumbar spine, signal to commence motion from the lateral hip while preserving a neutral pelvis. Excessive hip rotation, maintain toes facing front and prevent external rotation. Advancement and coding. Novices 2 sets of 8 to 10 repetitions each side, executed slowly and with control. Intermediate place, a light resistance loop band around the ankles or just above the knees, and advance to 3 sets of 10 to 12 repetitions each side. Advanced employ larger resistance bands or tiny ankle weights. Integrate single-leg balance exercises, eyes closed foam pad, once adequate strength and control have been achieved. Integrate with dynamic tasks, gradual lateral step-ups to simulate real-world disturbances. Considerations regarding frequency and neuromuscular factors. Pelvic stability is enhanced through regular reinforcement. Brief daily practice sessions, 1 or 2 sets daily, typically surpass occasional intensive sessions in terms of motor learning and pattern retention. Regular low-volume exposure enhances coordination and timing, which immediately translate to the requirements of single-leg support on stairs. Clinical recommendations. Due to the prevalence of abductor weakening following hip discomfort, surgical intervention, or disuse, initiate cautious measures and prioritize movement quality. Pain-free activation and incremental loading promote tendon adaptation and diminish secondary compensatory responses. 4. The sit-to-stand restoring functional strength. Objective and operational significance. The sit-to-stand exercise promotes coordinated hip and knee extension in a manner that roughly aligns with the requirements of stair climbing. It cultivates the capacity for rapid force production power, which is frequently a more accurate indicator of mobility and fall risk than peak strength alone in older persons. Enhancements in sit-to-stand power result in expedited and safer stair climbing, as well as an increased capacity to recover from disturbances. Biomechanical and physiological justification. Kinematic and electromyographic investigations indicate that the actions of rising from a chair and ascending a step exhibit comparable time and sequencing of muscle activation in the gluteal complex, quadriceps, and hamstrings. Power force generated over a brief time period is crucial for elevating the center of mass. Age-related reductions in type 2 muscle fiber size and neural activation diminish explosive force, yet intentional rapid sit-to-stands conducted safely can partially reinstate functional power via neural adaptation and hypertrophic stimulation of fast motor units. Thorough implementation 1. Chair. Utilize a robust, solid chair that positions the knees at approximately 90 degrees when seated. Refrain from using soft cushions that obstruct hip hinge mechanics. 2. Position. Sit in the front third of the seat with feet hip-width apart and slightly behind the knees. This foot positioning facilitates efficient forward trunk inclination and heel-driven propulsion. 3. Arm position. Cross the arms over the chest to inhibit the use of the upper limbs for propulsion. Arms at the sides or gently resting on the lap are permissible for individuals requiring help. 4. Commencement and implementation. Begin by inclining the torso forward until the nose extends beyond the toes, then exert force via the heels to achieve an upright position. Concentrate on explosive intent during the concentric phase, rise as swiftly as safely feasible, but refrain from jumping. 5. Descend with control by hinging at the hips. Refrain from dropping abruptly. Utilize the eccentric phase to enhance strength and control by descending over a deliberate 2 to 3 second duration. Advancement and modifications. Novices 3 sets of 8 repetitions with a 60-second rest interval permit a marginally reduced pace for individuals experiencing pain or possessing inadequate confidence. Intermediate aim for 10 to 12 repetitions, then striving for 15 repetitions within 30 seconds as a functional standard. Power emphasis. Execute stands with the intention of rising swiftly while ensuring safety, not an explosive leap. Upon achieving proficiency, lower the chair height to extend the range of motion or incorporate a light weight held at the chest. Eccentric focus. Gradually descend to the chair over 3 seconds to emphasize control and enhance the deceleration period. Evaluation and clinical standards. The 30-second sit-to-stand test and the duration required to complete a predetermined number of repetitions serve as valuable benchmarks. Completing 15 sit-to-stands in 30 seconds is associated with low reported difficulty in ascending stairs in observational populations. Progress can be quantitatively monitored and utilized to customize intensity. Clinical indicators to optimize transfer. Promote heel drive. Instruct to press through the heels to optimize torque in hip and knee extension. Trunk positioning. Recommend a slight forward lean to generate momentum. Severe trunk flexion may indicate an overdependence on momentum instead than muscular strength. 5. The heel raise with isometric hold. Cultivating propulsive strength. Objective and operational significance. Heel rises with an isometric hold engage the calf complex gastrocnemius and soleus, which significantly contribute to the propulsive effort necessary for ascending steps. The integration of concentric rise, isometric peak hold, and controlled eccentric descent develops both power and endurance in the ankle plantar flexors, which are essential for repeated stair climbing and for stabilizing the foot during toe-off during ambulation. Biomechanical and physiological justification. The plantar flexors produce a significant amount of propulsive force during typical walking and stair climbing. Age-related deficits frequently encompass diminished explosive strength and decreased endurance in the calf musculature. The incorporation of an isometric hold at peak contraction engages motor units, distinctively maintains type 2 fibers, and enhances the capacity to generate and sustain force rapidly. The complete range of motion descent enhances muscle tendon unit extensibility, hence boosting ankle dorsiflexion range, and elastic recoil, which contributes to eventual propulsive power. Comprehensive implementation. 1. Position. Stand with the balls of your feet on the edge of a stable step, allowing your heels to dangle freely. Gently grasp a railing or wall for stability. Avoid depending on the arms for elevation. 2. Concentric phase. Gradually elevate onto the toes to the maximum height, concentrating on a controlled and forceful ascent that prioritizes heel elevation over hip movement. 3. Isometric hold. Maintain the apex posture for 2 to 3 seconds to accentuate prolonged engagement at maximum contraction. 4. Eccentric phase. Gradually lower the heels over 3 seconds until they descend slightly beyond the edge of the step, experiencing a stretch in the calves. 5. Pause. Maintain a brief hold at the bottom for 1 second prior to repetition. Software development and advancement weeks 1 to 2. Perform double leg heel lifts 3 sets of 12 repetitions. Emphasize complete range of motion and controlled holding. Weeks 3 to 4, shift to 2 sets of 12 double leg raises and 1 set of 6 single leg raises for each side. Weeks 5 and beyond, advance to 3 sets of single leg raises, 8-10 repetitions per leg, extending hold duration to 4 seconds as tolerated. Frequency. Execute these exercises multiple times weekly, allowing a minimum of 48 hours for recuperation between high-intensity unilateral sessions. Rest for 60-90 seconds between sets to optimize power recovery while preserving training density. Execution specifics and indicators. Warm-up. Perform heel lifts, following a dynamic warm-up or other segments of the activity to optimize neuromuscular activation in warmed muscles. Mental imagery. Envision exerting force to propel the step away throughout the ascent to enhance neuronal activation. Imagery and concise mental rehearsal can enhance motor unit recruitment and coordination. Foot position. Maintain toes directed forward and equally distribute weight across the forefoot. Refrain from excessive inversion or eversion. Incorporation within a cohesive framework. Weekly organization and incremental advancement. These 5 workouts are most efficacious when incorporated into a unified regimen that acknowledges individual capabilities and facilitates progressive overload. This is an 8-week phased program appropriate for several older folks with fundamental mobility. Clinicians ought to adjust intensity, volume, and frequency according to baseline fitness and medical condition. Weeks 1-2. Foundation, neuromuscular re-education, and endurance. Wall sits 3 sets of 20-30 seconds performed every other day. Step downs, 2 sets of 6 to 8 repetitions each leg 3 times per week with extended rest days between workouts. Perform hip abductions, 2 sets of 10 repetitions each side daily or as often as feasible. Sit to stands, 3 sets of 8 repetitions performed every other day. Heel rises, 3 sets of 12 bilateral raises 3 times per week. Emphasis movement. Quality, gradual, eccentric control, respiratory rhythm, and fostering habitual compliance. Weeks 3 to 4. Capacity enhancement, augmented volume, and minor overload. Wall sits. Advance to 3 sets of 45 to 60 seconds performed every other day. Step downs. 3 sets of 8 to 10 repetitions per leg 3 times per week. Sustain a 3-second descent. Perform hip abductions. 3 sets of 10 to 12 repetitions per side daily. Use a light resistance band if feasible. Sit to stands. 3 sets of 10 to 12 repetitions performed every other day. Gradually increase speed with control to emphasize power. Heel raises 2 sets of 12 double leg repetitions and 1 set of 6 to 8 single leg repetitions 3 times a week. Emphasis develop endurance include asymmetry and enhance unilateral control. Weeks 5 to 8. Emphasis on power and specificity, increased intensity, unilateral focus. Wall sits 2 to 3 sets of 90 seconds or incorporate heel lifts during the wall sit for unilateral engagement. Step downs, 3 sets of 10 to 12 repetitions each leg. Use a minor external load or an elevated step only when technique is proficient. Perform hip abductions. 3 sets of 12 to 15 repetitions with increasingly heavier resistance bands. Incorporate balance challenges, foam pad eyes closed as tolerated. Sit to stands. Aim for 15 repetitions within 30 seconds, or incorporate a lower chair or small weight if 15 repetitions are readily accomplished. Incorporate concise, fast sets, 5 to 8 explosive repetitions interspersed with extended rest periods to enhance power development. Heel raises 3 sets of single leg elevations, 8 to 10 repetitions per leg, with a 3 to 4 second hold 2 to 3 times a week. Concentrate on transitioning to stair-like activities. Augment with practical stair practice in secure conditions, gradual controlled ascents and descents utilizing an accessible railing. Micro sessions and daily enhancements. Short daily micro sessions are beneficial for adherence and motor acquisition. A session lasting 10 minutes may comprise 1 set of wall sit for 30 seconds. 6 step downs per leg single set. Perform 10 hip abductions on each side using a band if available. 1 set of 10 sit-to-stands or 15 seconds of rapid sit-to-stands. 1 set of double leg heel lifts, 12 repetitions. These concise exercises reinforce patterns without inducing excessive tiredness and are particularly beneficial on days when extended workouts are omitted. Assessment of progress and outcome metrics. Monitor functional advancement with straightforward, reproducible assessments at baseline and every 2 to 4 weeks, number of sit-to-stand repetitions accomplished in 30 seconds. Timed climb of stairs over a certain number of steps or a specified vertical distance document step height and railing usage. Single leg balance duration, eyes open assessed for a maximum of 30 seconds. Timed up and go tug test. Patient-reported outcomes felt exertion during stair ascent, 0-0-10 scale reliance on handrails, confidence assessments, and incidence of falls. Clinicians must record both the quality of techniques and quantitative metrics. Minor enhancements in alignment, diminished trunk compensations, and decreased dependence on handrails frequently precede significant alterations in timed performance. Anticipations and customary schedules. The majority of individuals indicate subjective enhancements in stair confidence and diminished perceived exertion between 4 to 8 weeks of regular exercise. Quantifiable enhancements in timed stair climbing, sit-to-stand repetitions, and single-leg balance are typically observable during this time frame. Motivated individuals training regularly may have accelerated gains, whereas those with substantial comorbidities or chronic joint discomfort may advance more slowly. Anticipate initial brain adaptations, including enhanced coordination and timing within the first 2-4 weeks, followed by quantifiable improvements in strength and endurance from weeks 4-8 onwards. Adjustments for prevalent clinical situations. Knee osteoarthritis. Initially limit range of motion, avoid deep knee angles, emphasize eccentric control and pain-free loading, and advance gradually. Initially, utilize a chair with armrests for sit-to-stand transitions and restrict the height of step-downs. Anti-inflammatory approaches and weight regulation may facilitate progression. Balance impairment. Initiate with bilateral discrepancies and close hand assistance. Employ fingertip or minimal contact handrail support, initially advancing to unsupported movement as balance enhances. Parallel bars, harness systems, or monitored sessions are suitable for individuals with an elevated risk of falling. Hip replacement or significant hip pathology. Collaborate with the surgeon or therapist regarding weight-bearing restrictions and safe ranges shortly post-surgery. Commence with seated or supine hip activation exercises and postpone high-demand unilateral activities until authorized. Stroke or neurological impairment. Highlight the importance of repetition, a deliberate pace, external cues, and sensory input. Bilateral and aided modalities facilitate the reestablishment of motor patterns prior to unilateral advancement. Implement constraint-induced principles enhancing repetitions on the impaired side to facilitate neuroplasticity. Peripheral neuropathy or sensory loss. Enhance dependence on ocular and proprioceptive methods, minimize unstable surfaces promptly, and employ tactile cues along with supportive footwear. Balance training must be advanced judiciously. Strategies for adherence and behavioral assistance. Consistent practice is essential for lasting transformation. Basic compliance strategies encompass scheduling. Promote daily exercise at a consistent time to cultivate habit formation. Associating exercise with established routines, e.g. post-morning medicine, enhances adherence. Brief sessions. When fatigue or time limitations hinder practice, shorter daily sessions, 5 to 10-minute intervals, typically result in superior adherence compared to longer, irregular sessions. Record keeping. Sustain a concise log of sets repetitions and perceived difficulty to monitor progress and maintain commitment. Environmental stimuli. Position a resistance band adjacent to a chair, designate a step within the residence, or maintain a small weight in plain sight to diminish obstacles to initiation. Social support group classes, partner training, or community initiatives enhance accountability and enjoyment. Positive reinforcement. Acknowledge little achievements, e.g., decreasing reliance on handrails during brief ascents to maintain motivation. Diagnosing prevalent issues. Excessive soreness, decrease volume or frequency, augment recuperation days, and guarantee sufficient warm-up. Contemplate a temporary reduction in eccentric focus, followed by a steady increase. Ongoing joint discomfort during exercise. Reevaluate technique and joint alignment. Use a lower-impact alternative, e.g. partial-range heel lifts, reduced depth sit-to-stand, and seek clinical advice if pain endures beyond 72 hours or is accompanied by edema. Plateau in progress. Modify the training stimulus, e.g., brief power emphasis in sit-to-stands, adjusting band resistance for hip abductions. Reevaluate baseline metrics and verify adherence consistency prior to intensifying the regimen. Anxiety regarding stairs. Implement graded exposure, begin with a single step, and progressively escalate complexity while practicing newly acquired movement patterns. Integrate breathing and relaxation techniques to alleviate fear. Clinical vignettes, exemplary illustrations. Mrs. A, 72, with mild knee osteoarthritis, initiated the foundational program with diminished wall sit depth and partial range step-downs. By week 6, she was able to ascend 3 flights of stairs without a handrail and noted a 50% decrease in perceived exertion during family visits. Objective metrics sit-to-stand performance enhanced from 9 to 14 repetitions in 30 seconds. Single leg balance raised from 6 seconds to 16 seconds. Mr. B, 68, 6 months. Post-knee replacement. With clearance from the physician and therapist, advanced from double-leg heel, rises to single-leg variations. During a 10-week period, he enhanced his single-leg balance duration from 5 seconds to 20 seconds and progressed from descending stairs with assistance to descending independently with diminished apprehension. Ms. C80 exhibits balance impairment and neuropathy. Initiated with seated hip abductions and partial sit-to-stand transfers, advanced to standing hip abductions with minimal assistance, and subsequently to low step-downs. Over a span of 12 weeks, she indicated less dependence on handrails and enhanced confidence while ambulating in communal environments. Constraints, research deficiencies, and prospective trajectories. Although clinical programs and replication studies indicate significant improvements from targeted pattern training, numerous questions persist. Optimal dose for various subgroups. The most efficacious frequencies, durations, and intensities for frail older folks, individuals with advanced osteoarthritis, or those with cognitive impairment require more elucidation. Long-term retention. The extent to which these neuromuscular pattern improvements endure without continuous practice remains inadequately elucidated. Maintenance techniques and the minimal effective dose for retention warrant investigation. Independent contribution of each exercise. While the 5-exercise regimen is synergistic, assessing the individual impact of each component and whether a reduced number of exercises could yield comparable results would enhance efficiency in practice. Technology integration. Exploring biofeedback, wearable sensors, and telehealth-guided programs to improve motor learning and adherence is a promising field. Expanded population studies. Larger randomized controlled trials comparing pattern-focused interventions with traditional strength-only programs across varied populations, rural areas, multiple cultural contexts, and differing comorbidity burdens might elucidate optimal practice recommendations. Conclusion: an integrated pragmatic initiative to rehabilitate stair mobility. The 5 exercises outlined: wall sit step-downs, standing hip abductions, sit-to-stands, and heel lifts, with isometric holds form a cohesive synergistic regimen that addresses the essential physiological elements necessary for proficient and assured stair navigation. Each exercise targets a specific yet interrelated component: isometric endurance for sustaining supportive positions, eccentric control for safe descent management, lateral stability for maintaining pelvic alignment during single-leg support, functional power for rapid upward force generation, and ankle propulsive capacity with endurance for repeated steps. Collectively, these activities recondition neuromuscular patterns instead, then only enhancing isolated maximum strength. Clinically, programs based on these principles have yielded swift and significant enhancements. Extensive clinical cohorts indicate high percentages of patients achieving improved stair navigation within 8 weeks, and controlled trials have recorded considerable advancements in stair speed, perceived exertion balance, and functional autonomy when specific patterns are systematically trained. Clinicians and older persons can organize the exercises into routines that align with present abilities and gradually advance. A representative weekly regimen combines infrequent high-load sessions, e.g. step-downs, single-leg heel lifts, with daily low-volume pattern reinforcement hip abductions, brief wall-sit holds. Adherence to correct form, moderation of initial intensity, progressive advancement, and consistency are essential for safety and efficacy. Individuals with substantial joint pathology, pronounced balance deficits, cardiovascular issues, or other medical conditions should seek guidance from a healthcare professional prior to commencing exercise. Modifications, such as abbreviated holds, limited range of motion, and additional support for balance, can be implemented to address limitations while effectively training essential neuromuscular patterns. The research indicates a transition from generic strength training to tailored pattern-focused exercise to rehabilitate stair-climbing capability in older persons. Through the methodical training of isometric endurance, eccentric control, lateral pelvic stability, functional power, and ankle propulsive capacity, older persons can restore confidence and competence in stair navigation, maintain independence, and expand chances for active living. Through meticulous screening, regular practice, and incremental overload tailored to individual capacity, these exercises provide an effective, economical, and adaptable solution to a prevalent and significant mobility issue. Every day you choose to move, your body responds with strength, balance, and renewed life. Each gentle motion is a gift to yourself, calm, mindful, and full of vitality. Together we move, we heal, and we thrive. Keep the rhythm of your golden years. Nurture health, cherish every movement.